And welcome to Trauma Y and Crash. I'm Wyman.
And I'm Lonnie. And before we get started, I'd like to say, go Browns. 2-1.
I'll take it.
10-1 would be better, but this podcast and slideshow will be about intravenous catheters. Overview. Started. I would like to do a shout out to Jay Sachs, who provided the music. The sound is Airborne to Cali. It's single, can be found on iTunes. So you get a chance, pick it up. It's a good song. The content of this presentation will be why should nurses be able to start IVs, the size and type of angiocaths, what's in an IV start kit, signs and symptoms of IV infiltration, extravasation, and phlebitis, how to find a vein, and the two types of techniques. Must be able to start and maintain IVs. I believe that 99% of patients in the hospital will require IV access. Nurses need to be able to recognize the signs and symptoms of infiltration, phlebitis, and extravasation of IV fluids. Our patients' IVs are their lifeline. And most codes that happen are not always in the ICU. Most of them, I think, happen on the floor. So it's very important to have IV access because in most code situations, you lose your blood pressure, which makes it difficult to find IV access. So if you have an IV prior to coding, it gives you a better chance and less likely of delay of care of getting fluids or medications into the patient. And most facilities that have patients on tele require you to have IV access, which is a good thing. Sizes of IV catheters or angiocaths. I'm just going to go into four that I see most of all in most hospitals. We go with the 18 gauge, which is green, which is the largest that we use in the hospital. There were 16 gauges, but those are more trauma-like. The pink, which is a 20 gauge, which is used most often. Blue, which is 22, and yellow, which is a 24 gauge. The bigger the number, the smaller the needle. Most floors, if you have a patient on the floor, you put in a 20 gauge. That pretty much can handle fluids and medications. If you're in the ED and you come in, you usually get an 18 gauge. Blue is for people who have maybe getting just medications such as low pressure, things of that. You put a 20 gauge in and you're fine. You don't need anything bigger. Now, for the little ladies that have little tiny veins that you can't find, 24 gauge would be used. They also have trauma lines, which you won't discuss because those are basically for trauma patients in the ED. Yes. They'll differ from facility to facility, so I'm just going into a basic kit you might find at your facility. We have saline, which sometimes it's separate from the IV kit. I think most of the time you have to get that separate. You have a tegaderm dressing, which is kind of a clear off-site dressing that makes it easy to see the IV where you inserted it. And you want that because if you get phlebitis or inflammation, or if it's leaking, you need to see that before it becomes too bad. And with the clear dressing on there, you can just gaze at the IV site and see what's going on with it. You have a tourniquet, which you use to tie around the extremity to backflow, so it makes it easier to start an IV. You've got tape, alcohol. Now we're using ChloraPrep, so a lot of times you have one or the other because ChloraPrep cleans a little bit better and helps to prevent infection. And you have a J-loop, which is pretty much just a little tube to extend the IV. So when you place the catheter, you hook the J-loop, so if someone tugs on it, they'll tug the J-loop and not the IV in the beginning. Where are your veins? You need to know where to find your veins to start an IV. Most people are basically the same. There are some people whose veins are in a different spot or maybe a little bit anatomically moved, but for the most part, you have an idea where your veins are. A map of the IVs and veins, excuse me, in your arm. Please excuse the picture; it's not as clear as it should be, but you can get an idea. You've got the cephalic vein, which is running right here. You also has the accessory cephalic vein, which is running closer to the outer part of the arm. You have the median vein, which is in the middle. Usually the one we look for the most is this one right here because it's usually the biggest and it is the easiest to access. We've got a couple of more over here, which I won't go into, but you see how the veins are mapped out. So if you stay within the area, you should be able to find that vein. Not always, but you should be able to. About what is a vein finder? A vein finder is a device that is used by nurses to visually locate veins. It is a very, very good machine to have. It's almost like an X-ray. Basically, you use this, it's like a light, and you hover over the arm and it lights the veins up so you can see them better. The only issue that I have with the vein finder, it does not tell you how deep the vein is. It gives you an idea where it's located, but you have to be careful that you're not going too deep to find the vein because it doesn't give you depth. But it is very, very good in accessing veins when you have difficulty doing so. One of the most important things you need to know is about extravasation. Extravasation must be, excuse me, taken very seriously. Extravasation is the injury and destruction of tissue caused by leakage or infiltration of a vesicant into surrounding tissue. And as you can see in the picture, it looks very, very bad. And basically, it will cause, I'll go into the last one here, sloughing of the skin, which pretty much means this area here will basically just fall off if it's not treated appropriately. Signs and symptoms is redness, swelling, coolness at the site, pain at the site, blistering at the site, and sloughing of the skin, which is basically the falling off of the skin. Pretty much, it's very, very nasty. For extravasation is stop the infusion immediately. As soon as you notice it, you must stop the infusion. Second most important thing is leave the IV in place. Do not remove the IV. You need to be able to put medication in the same way that the infusion went in. Next, try to aspirate as much of the medication back through the IV as possible. Then contact pharmacy for medication if needed for an antidote. When giving the medication, make sure you inject the meds into the IV and the surrounding tissues. You want to get the medication in the same route as the other medication in that causes the extravasation. You also want to inject around the area, so pretty much you're surrounding the tissue so it doesn't spread, and that way it'll leak into the medication into the skin and neutralize it. So like I said, do not pull your IV. It's very important that you leave that IV in once you notice that you have an extravasation. Guidelines to follow. Please follow the policy and procedures of your hospital or facility. Contact pharmacy to find what medications are necessary to be given. They will go by the policy and let you know what you need to do to take care of extravasations at your facility. Next, we're going to go into IV infiltration. IV infiltration is the leaking of IV solution in tissues around the IV site that are non-vesicants. So they don't do as much damage as extravasation. And most of the, if it's IV fluids, is absorbed into the tissues. Signs and symptoms are swelling and puffiness at the site, coolness at the site, blanching, and pain. Infiltration of fluids is elevate the extremity. Use a warm or cold compress on the site for 15 to 30 minutes. 15 to 30 minutes on, 15 to 30 minutes off, depending on the policy of your facility. And always assess your site frequently. Go back and take a look and make sure that the swelling is going down and that the treatment is working. About phlebitis, which is inflammation of the vein that could be caused by thrombophlebitis, which is caused by clots or a clot in the vein. Signs and symptoms are redness, swelling, warmth at the site, or a red streak going up the arm. If you see a red streak or redness going up the arm, you can be pretty sure it's phlebitis, more than likely. This is the same as infiltration. Elevate the extremity. Apply heat only. Why? Pretty much if it's a blood clot, ice will not reduce the swelling. It may make it worse. Some physicians will prescribe anti-inflammatories medication if needed. And again, go back and assess your patient after your treatment to make sure that the treatment is working and that the clot isn't getting bigger or it's moving down. So always when you do a treatment on your patient, go back and check to make sure it's working or not working. Reassess your patient as much as possible. Ways to start IVs. Everyone has their personal preference on how to do it. I particularly have two. The first approach is by taking your catheter, needle, and going horizontal to the vein. A lot of people like to start, and I guess that's how they were taught, at a 45-degree angle and then go down. I don't like that technique because a lot of times you go through the vein before you realize it and you blow the vein. My way, I like to get as close to the skin as possible and then insert the catheter until I get blood and then advance it. It works for me. Like I said, everybody has their own personal way, but I'm pretty good at it and I like my technique. The second method is, especially when you have older people whose veins tend to move from side to side, I pretty much take my left hand and fingers and kind of pull the vein tight to the side, as tight as I can, and then insert the catheter into the side of the vein and then advance it. It is a little bit more difficult because you are more likely to go through the vein if you go push too hard, but it's one way of getting the vein taut so it doesn't move or wiggle from side to side. And also, as far as other ways of doing IVs, we have what is called a PICC team, and I think most hospitals do. When we can't get an IV, we tend to call the PICC team to come in because they have what is called an ultrasound, which is something like a vein finder, but it goes much deeper. And they are able to start IVs or place PICCs into people that we can't get IVs in. Having an IV is a necessity in the hospital for most, if not all, our patients. Nursing must have the knowledge and skill to start and maintain IV access. Nurses must be able to recognize problems with their IVs such as phlebitis, infiltrated sites, and especially extravasation of IV sites, and how to treat the complications to provide the best care possible for their patient using their facility's policies and procedures.
Assess your patients.
Always assess your patients. Whatever you do, if you do anything to change anything, assess your patients. If it doesn't feel right, find out why. All right, please subscribe so I don't get in trouble. This man is just, subscribe to our channel and hit the like button. Even if you don't like us, hit the like button so you can come back and complain again.
Give us comments. Tell us what else you want to hear. We have assessment YouTube's coming up here soon. Look forward to hearing from you. And again, J Sachs, Airborne to Cali, available on iTunes.